All right, it's now my pleasure to introduce our speakers. So Brian, I'll ask you to bring the next slide up. And as we do with all of our educational activities, it's important that presenters disclose any potential conflicts of interest or financial support. So I will introduce our speakers and then I'll ask them to review their disclosures for you. So first on the list is Genevieve Bois. So Genevieve is a family physician who works with the Cree community on the shores of the Hudson Bay. Genevieve is also a clinical teacher at McGill University and the University of Montreal, where she's in charge of the Indigenous curriculum for the Faculty of Medicine. Genevieve's interests and her advocacy revolve around Indigenous medicine, reproductive medicine, and the issues around overdiagnosis. So welcome, Genevieve, and would you please say hello to our viewers and review your disclosures for us now.
Wachia, everybody. My name is Jen, and I work in the community of Wamakshtu, Cree community on the Hudson Bay. I'm not myself Indigenous, and I don't speak for the Cree or any First Nation today. I am here simply as a healthcare worker who has been working and living in a fairly remote community for the last 3 years. I don't have any financial support that I need to disclose, other than I'm on the board of the Quebec College of Family Physicians, and I'm on the governing council of NCD Child and NGO working around NCDs. But otherwise, I don't receive any type of support from a private company.
Thank you, Jan. Our next speaker is Dr. Jane Philpott. Jane is a family physician and a former politician. Jane is currently the Dean Designate at Queen's University and at the Faculty of Health Sciences. And Jane is going to be speaking to us about her firsthand experience working as a clinician in a group home in the Toronto area for physically challenged folks with disabilities. So Jane, welcome, and please review your disclosures.
Thanks, Janice, and hello, everyone. I'm very pleased to be here. With regard to disclosures, I have received speaking honoraria from the universities that are listed on your screen, and I am a member of the editorial advisory board of the CMAJ. No other disclosures.
Wonderful. Thanks very much, Jane. We look forward to hearing about your experiences and yours as well, Jen. Next slide, please, Brian. Okay, our third speaker that's joining us today is Dr. Jeffrey Turnbull. Jeff is the founder and the medical director for an important organization called Inner City Health Ottawa. This is an organization that provides and promotes health well-being to chronic and homeless individuals. Many of you may know Jeff as a past president of the Medical Council of Canada, the Canadian Medical Association, as well as the College of Physicians and Surgeons of Ontario. And also important is Jeff has been past medical advisor for Corrections Canada, which is also an important vulnerable population. So welcome, Jeff, and please review your disclosures for our audience.
Thank you very much, Janice. It's a pleasure to be here. I don't have any specific disclosures from a financial perspective. All of the revenues I generate come back to Inner City Health.
All right, thank you very much. And lastly, for myself specifically, I am a paid employee of the College of Family Physicians of Canada in my role as physician advisor and continuing professional development. I also receive stipends or honorariums for my teaching activities at McMaster University within the Department of Family Medicine, the Centre for Simulation-Based Learning, and also through the Ontario College of Family Physicians. All right, so the last item of business is to review our learning objectives. And certainly at the end of this informative session, we hope that you as viewers will be able to describe factors that lead to increased vulnerability of our already at-risk populations, certainly during the pandemic. We hope that you'll be able to recognize certainly some of the challenges that encounter during dealing with specific populations, such as patients with developmental disabilities within a group home setting, those Indigenous populations or those who live in a remote community, patients in correctional facilities and also those that are in homeless or long-term shelters. We also hope that you'll be able to identify other populations that you may not have thought about as vulnerable, but have come to light during this particular pandemic. So with that, we will now start right in with the questions. And this, the first question that I'd like to review is with respect to, I'm going to have everyone's perspective on this, and it's with regards to the actual social as well as health systems factors that have led to an increase in vulnerability to the already vulnerable populations. And I'm going to ask each of you to speak about the particular population that you work with. So Genevieve, I'll start with you. If you can think about and let us know what social and health systems factors have contributed to this population being even more vulnerable.
So certainly I'm probably not telling anybody new when I say that there are significant issues with houses being in need of major repair or being overcrowded in a lot of northern communities. This is certainly something that we see in many settings, and that is already a huge concern in non-pandemic times, and obviously is a massive concern in those times of pandemic, because this means that if the epidemic enters the community, it will be very difficult to contain it to a few individuals, since people live many to a house, and those are also multi-generational dwellings generally. So that it was already an issue, and it's certainly much more now. In the community where I am, we do have good access to clean water, but unfortunately that is not the case across Canada, and that is certainly an unacceptable situation, which was already unacceptable, but is probably coming to light even more now. And also our healthcare system is, fairly limited, where we have dispensaries in a lot of communities, but those, what they used to be called nursing stations, those clinics don't have a lot of resources, whether human or material, and that limits our ability to offer extensive care, both before COVID and currently. So we have to be very mindful of that. We also rely on a workforce in terms of clinic that is very much fly in, fly out, which is a concern for importation of the virus, and I think brings to light something that was already important, but it's even more important now, which is to have more Indigenous nurses and physicians to serve their own communities better.
Thank you, Jen. That's it highlights a huge important point, and around recruitment of physicians who are willing to not only service special populations, but to travel as well. And it is so very, very important. Thank you. Jane, I'll turn to you now to ask you to speak about those factors.
Thanks, Janice. And perhaps just to set a bit of a context for the responses that I'll be giving. We'll be speaking specifically to my experiences over the last 6 weeks, helping out in a place called Participation House, which is a group home in Markham, Ontario. It is home to 42 severely disabled adults at a range of ages, and they are mostly non-ambulatory. Only 4 of the 42 were able to walk by themselves without assistance. And this community was affected by COVID with a very serious outbreak. 40 of the 42 residents in the home contracted COVID infection. 56 of 98 staff contracted COVID. And unfortunately, 6 of the residents here died. So, I think one could come up with a long list of factors that have made this population more susceptible in this context. But I think I wanted to highlight 3 in particular. One is from a health systems perspective, and that is the crazy fragmentation of our health systems. In Ontario, we now have a Ministry of Health, a separate Ministry of Long-Term Care, and a place like Participation House that actually actually doesn't fall into either of those. It falls under the Ministry of Children, Community and Social Services. And so to a certain extent, the whole facility and the people who live here are outside of the view of the Ministry of Health, and were not part of the considerations in pandemic planning at the outset. As people have talked about, other than myself, our focus in the early days of the pandemic across the country really was very hospital based, and many of these long-term care institutions and other congregate settings were really not in the priority. The second area is just factors relating to people's disabilities themselves that make them much more vulnerable and in many ways invisible to the public eye. They're the voices of the people who live in a place like Participation House are quiet. They can't get themselves heard the same way that a CEO of a hospital can get themselves heard. I wanted to just read to you the email that was sent by the executive director of Participation House on Easter Sunday morning to a friend of mine who was on the board of Participation House and wanted to get in touch with me. And she wrote, "We are in desperate need for staffing. There is no light at the end of the tunnel after 2 days of pleading for help. And I need Jane's contact and I need to ask her for help and support today." So this is the executive director responsible for 42 severely vulnerable individuals, spent 2 days trying to get some attention, knowing that 40 people were infected in the home and that the outbreak had already been declared for 3 days by the time she finally got through to me. So that speaks, I think, to the invisibility of a population like this. And the third area I would just say is in the public health factors, and that have to do with how hard it is to do physical distancing in a place where people don't necessarily understand what's going on, where they are used to being fed in group settings, and there were very serious shortages of staff, which I'll discuss later on. But those are just a short list of some of the reasons why places like this were highly susceptible to a serious outbreak.
Thanks so much, Jane. I think a lot of our colleagues are experiencing exactly what you've spoken about regarding the fragmentation of our healthcare system. It's really brought to light. It was interesting. I read an interesting quote saying that a pandemic sheds light on what's fundamentally inequitable in the world we already live in, and I think we're all seeing that firsthand. So thank you for that perspective. Jeff, I'm going to turn to you and ask you to speak from your perspective with the homeless.
Well, I think you're going to find several very common themes here. And just as you said, Janice, that people have called the COVID-19 the great equalizer. I don't think that's true at all, frankly, even though it does strike all levels of our community and society. I think the major burden will be borne on the back of the poor. And in my context, that's the homeless. So if you understand the context that I live in, it's 1,000 homeless people, almost all with mental health and addiction. And at the same time, this is not their primary expectation for them. They're busy dealing with the voices or their addiction. And so at the same time, when I talk to them or others talk to them about social distancing, about isolation, they basically smile because those are admonishments that are not directed to them. How can you socially keep a distance when you have to line up for a meal with 200 other people, or when you sleep in a group room of conjugate living setting in a shelter with 70 other people? That's not possible. Or if you have a fever and you're tested and people say, well, just go and isolate. Well, where is that going to happen? There are no isolation facilities and no opportunities for isolation. So they're vulnerable because they have so many comorbidities. They aren't able to protect themselves or those around them, and they sit at risk, and they know that, and they feel that they have been neglected by those people who are responsible for their health around them. So they're very vulnerable. But I would say that, frankly, their vulnerability is not new, nor is all the other speakers. We would all know that those are vulnerable populations. It's just taken COVID-19 to highlight just how vulnerable they truly are.
Yes, exceptionally sobering thoughts. And Jeff, you must also have a similar perspective for those patients when you were medical director in the correctional services. Anything additional from that perspective?
Yes, there are the people in our correctional facilities, either provincial or federally. Those people live in overcrowded circumstances, no opportunity to keep a safe distance, etc. No access to personal protective equipment, by and large. Like many of the homeless, no opportunity for, or little opportunity for hygiene, etc. So they find themselves very vulnerable, very much at risk, and they're very sensitive to that. And efforts have been made to try and decongest the prison system, but still, facilities that were set up for one person in one room have 4 to 6 people in a room, and those are rooms that are 8 by 12, in many circumstances.
Certainly a very sobering situation all around. So for our viewers, family docs, really what I know a lot of our colleagues are interested in are the things that they can do, or what they should be looking for when they see patients from vulnerable populations. So what I'm going to ask each of you to do is to share if there are some specific unique signs or symptoms that we as family physicians should be looking for if we encounter someone in a higher risk or more vulnerable population. And it's not just the populations we've already mentioned. There are other more vulnerable populations, certainly that that we're seeing with in situations where there's overcrowding and for immigrant populations and mental health and physical abuse and shelters and those kinds of areas as well. So I'll start with Genevieve. If you can, are there anything, with respect to COVID and any unique signs or symptoms that family docs can be on the lookout for?
I think most physicians that will see the patients I see or already work in a more remote community or will be receiving them in centers in the South. So more specifically, I would say, to be kind and patient with the fact that when we transfer patients, we might not have all the information you want, because for us, getting lab results can take days. Getting a COVID test can take days to a week. We don't have any labs on site, so we might need to transfer a patient whose COVID status unknown, or who hasn't been scanned, or who hasn't been hasn't been worked up in a way where that we usually work up patients in the South. So we have to make those decisions based on very limited information about who we transfer and when. And obviously the main factor for this are the patient's wishes and the family's wishes, but the care that we can provide locally is quite limited, and therefore we might need a lower threshold for transferring patients than in other settings, just because it takes so long to transfer somebody that if we wait until they very, very badly need it, we might be in a precarious situation. The signs and symptoms of COVID, are mostly the same for all adults, but I think an additional challenge in a population where there's a lot of respiratory comorbidities is trying to tease out what is a new chest discomfort, what is really a new or worsened cough. And we might need a lower threshold there too, because people have chronic respiratory symptoms and that do tend to fluctuate. And therefore, what is a significant difference that could be COVID might not be something that's easy to tease out.
Yeah, very good points about the comorbidities. Thank you. Jane, let's go to you.
Well, I'll just speak briefly to my experiences with the population that I've worked with most recently. And I think there's still a lot to learn, and I don't know that it's fair to generalize the experiences here because it was 40 people that were infected. But certainly one of the challenges in terms of signs and symptoms is that it's extremely difficult to get a medical history. Many of the residents here are nonverbal. The 90% of the staff had to leave when the outbreak happened for a variety of reasons. And so there were very few people on site who actually knew what baseline was for people. So we had some real challenges in terms of determining whether a neurological status was unusual or not. But I would say in terms of things that I learned that might be helpful, that if I were doing this over again, I would wish I knew on day one. And I would say, this place is people's home. It's not set up as a clinical facility. And so, there was initially no system for doing vitals on a regular basis. And there was not an oxygen saturation monitor in the place. And so I don't know what kinds of circumstances people might find themselves in if they go to help at a long-term care setting or whatnot. And I think the facilities will differ from place to place. But for me, I came to learn that monitoring of vitals was one of the most effective things that I could do. Like Jen, we didn't have access to laboratory and other diagnostics here, but even with checking O2 sats on somebody was a really good indicator. I guess the other thing I would just say was that in my experience, the people who didn't do well had rapid sudden changes, and it was not unusual to have seen somebody who seemed relatively stable and get a panic cry from someone to go and check on a resident who had been seen 15 minutes earlier that had suddenly started to desaturate and become much less responsive. And so it is a challenging illness in a population that you don't have the same indicators for to determine when they're going to deteriorate.
Wow, yeah, that's can be unnerving at best, and certainly but a good reminder for everyone to keep their higher vigilance for those kinds of signs. Jeff, over to you in the homeless area.
Well, on a good day with my homeless, many have, as we've heard, chronic obstructive lung disease or infections from many other different causes, whether they're shooters, abscesses, or pneumonias. On a good day without COVID, I would probably see 4 or 5 of those individuals with new onset symptoms. Now we have to raise into the question whether they also have COVID. If you add in the atypical symptoms, there are very few people in our shelters that would not have either a typical or atypical symptom. And the atypicals, as everybody knows, might be diarrhea, confusion, weakness, etc. So add those things into typical symptoms, and it is preciously difficult to sort out which is COVID and which is not. Fortunately, we know the homeless very, very well, and we know who's had prior infections, and this is nothing different out of the ordinary. But for those people who don't, all I would say is that we've learned that there are many homeless who are asymptomatic. We've also learned that many are symptomatic with atypical symptoms. I would have a very, very low threshold of testing whenever they're encountered. And frankly, we've gone from targeted testing to institutional testing of all of our shelters in a broader testing strategy.
Thank you, Jeff. That's a very important, issue that I'm going to actually address next, because and certainly it's a question that's coming from our audience viewers, is this whole issue around testing. And certainly in some literature that I've read recently, that I understand that in communities where there's a higher concentration of residents and people living, and even in communities or shelters, that COVID tests are twice as positive, or twice as likely to be positive in in those particular settings. Jane, I'm going to turn it over to you for a question from our viewers with respect to testing. And as Jeff had just mentioned, there's been in his population a recent switch in the surveillance testing. What about what's your feeling on swabbing of not only residents but staff in institutions or vulnerable settings with perhaps pooling samples in batches to save on costs, perhaps? Has there been any thoughts around that or discussions within your colleagues, or you thought about that from your experience?
Well, we've definitely thought a lot about it, and I'm not sure that anybody knows exactly the right answer from a testing of staff point of view. Absolutely, any of these vulnerable populations, widespread testing of populations at risk is really important to be done. When it comes to the staff, it's a little bit harder over a long period of time because, as everyone knows, you can test negative one day and become infected and therefore infectious within a few days, and there can be some false reassurances to having had a single negative test. Having said that, I would say one of the lessons that we've learned through this experience is that testing of staff in institutional care is really, really important because for one thing, you're short-staffed already, and there's a real fear around the testing because we were faced with many weeks where people would test and recover quickly, and we basically couldn't function without them, and we had to return people to work as critical personnel as early as possible once their symptoms had resolved, with using just the 48 or 72-hour marker after symptom resolution, and they were obviously using appropriate personal protective equipment. But I think if I could do it again, I would say we would do more regular testing of staff because in large institutions, it spreads quickly. You have people in our circumstances here that were living in hotels because they were self-isolating from their families, and we believe that there was cross-contamination possibly of staff in those kinds of settings as well, even though obviously everyone had been given all of the right instructions in terms of physical distancing. So I think we still have more to learn, and my personal bias is that we need to push the system strongly on testing of not only vulnerable populations, but those who serve them. And the testing our provinces are going to have to find a way to be able to maintain capacity to manage that. But in terms of how frequently that's done, I think there's still lots we have to learn.
Okay, all right, thank you for that. I'm going to also, you mentioned an important point around, social, isolating yourself and for workers. But what about the patients? And Jeff, this pertains to you and Jen. In crowded situations, how do you isolate? And what things do you need to do? Does our public health system need to put in place to help with that whole situation, or that whole issue around isolation?
So perhaps I can begin. When we started thinking about the issue of testing, first of all, there's this issue of trust that the clients have to be supportive of you and know you in that environment. So we fortunately had that advantage, and then we could test. But then we said, so what? What happens if we find somebody who's likely positive or is positive while we wait for their test, or they're proven to be positive? Where could we put them? What's the, don't do a test if you can't respond to it. So what we did within the space of a week, which shows you actually how much change can take place if you're motivated, is we took over a community center and created an isolation unit to hospital standards, all done within 1 week, And there we isolate all of our either pretty sure we're positives or positive scans, tests. And in that context, then we have something that we can do if we actually test somebody. So at first we had some challenges in getting test strips or testing facilities and stuff, but now we have the tests, and now we're doing more widespread testing, and we can isolate them into an environment. So there is something you can do about it.
So when you say you can isolate them in an environment, if they're, for instance, if they're ill and you feel that they need to go to hospital, are there particular differences that, you know, when you speak to the emergency physician that's on at the emergency department, are there specific things that you can relay that should be looked out for? Does the topic of advanced care planning ever come up when you're sending your clients to shelters, or sorry, from a shelter?
Absolutely. So when we send people to our isolation center, they may be minimally symptomatic or asymptomatic. And we have a series of criteria for when we would transfer them to the emergency department based on their oxygenation status, the amount of oxygen they're requiring, etc. So, and comorbidities as well. So we would normally keep those people and not transfer unless they started to deteriorate. And every one of them, we have a conversation about advance directives so that we're very, very clear what they want, where they want it. And I have to say, many of them say that they would like to still continue to be cared for, even if they deteriorated right in the shelters where we work with the people that they're familiar with. So we've even built in palliative care into our isolation unit.
Well, that's very interesting. And I've also been reading that there's been a couple of facilities, at least in Toronto, that have been set up, and hotels that have been also been put to good use by offering rooms for that whole purpose around isolation.
Yeah, and what we've also interestingly done is we've had to decant many of the shelters. Remember, I told you about a room with 70 patients in it. But most people are living in a conjugate setting of 6, perhaps 8 beds. Well, we've reached out to our local hotels around us, and we've moved many of our clients from the shelters to decongest the shelters into those hotels. And the hotels have been very good about this. And whenever we've got a real concern about an outbreak in a facility or just positive tests, then in those settings, we'll move them to the local hotel where they can be in a private room setting.
Excellent. Genevieve, I'm going to turn to you now with a question with respect to future planning, whether it's for this particular pandemic or a second wave. When you're thinking about planning and what needs to be put in place in a remote area, and then, you know, sometimes remote areas can be protective if governments act quickly. You know, I have personal experience with that from volunteer work that I do down in Grenada. But oftentimes it doesn't. So I'd be very interested in your perspective about what you think needs to be put in place for planning for remote areas.
It definitely is a double-edged sword, and, you know, this needs to be highlighted, that being a more remote community protects you, but also puts you at increased risk if the virus does enter the community. So the focus has been in many more remote regions around the world to simply try to get the virus to not enter, and if it does, to be extremely aggressive about testing and tracing and isolating. And I think that's something we're just going to have to keep up for a really long time. Obviously, you can't cut off a community from the rest of the world for months to years, but, you know, minimize ins and out, necessary quarantines in some cases, and, you know, really minimizing the amount of people you interact with. Certainly, there are things that we should have done, but it's not the right moment to do. You know, I hope this gives an impetus to build a lot of houses in all those communities, because it's been badly needed for a long time, and we've just had an extra proof of it. But I think rightfully so many communities would be uncomfortable with an influx of construction worker at this time. So it might be something we need to do relatively urgently, but we can't do as urgently as we wish. I think we need to certainly keep giving support to those communities and the clinics there in terms of, having backup remotely to support you and helping with material resources. It is very difficult. Everybody's putting in a lot of orders and everybody wants, those masks and those gowns and those concentrators as fast as possible. But I think we do have to prioritize areas in Canada where this can have a disproportionate impact. And we've been lucky so far in the community where we've had access to a good amount of tests, and we've not had to ration the testing like as been the case in certain places. And it's something we're going to need to continue to do. We're going to need to continue to, test aggressively, even if we have lower positive rates than other places. Like our positive rate in the community where I am has been 0%. But that doesn't mean we should slow down because once you get one case, there's probably many people that are already infected, and it puts everybody at a massive risk. But if we want to prepare for, next pandemics, we really need to strengthen health systems and social housing. And that's an issue, for many populations that are living in a structural vulnerability position at the moment in the North and not in the North, Indigenous and non-Indigenous community. There needs to be a huge push for this. And I'm worried because I wonder if after the pandemic, people are actually going to want to cut services because they're going to feel like we spend so much during this pandemic. But if there is a time to invest massively in health and in housing and in good and nutritious food, the time is really, really now. And I like that Jeff highlighted it, but there's been so many op-eds and comments in the media about how COVID is an equalizer and we're all equal and together in front of COVID. And nothing could be more inaccurate. And all of us see it every day. There are people that are at, a much, much higher risk than others and stand to lose a lot more. We are not equal in the face of COVID, and we've never been equal in the face of any infectious disease. So I don't know why this would have been different.
Okay, yeah, you're right. That some important points around planning, because no doubt this has happened before, and it'll certainly happen again. Jane?
Yeah, and we see that if we could do those things all along. When I see people talk about those hotels that we've repurposed, and my friends and my colleagues work in those hotels, that means we could have housed people all along. There was never really, an inability to do it. This is a question of political will. And now that we're worried because of COVID, all of a sudden, all those options are in the realm of possibility. Now we can house people. So I think we need to remember that and not be satisfied with the status quo after.
Yeah, some very important lessons learned for sure. Jane, I'm going to turn things to you with a bit of a different perspective, because we've touched on some vulnerable populations, but we all know there are many more out there. And I think I mentioned a couple of them. And one of them is with your experience with working with patients with disabilities. There's a little bit of a twist in that to look at this from a perspective for individuals who are still living in their own houses with their families, and caregivers are coming in to their homes. And what pieces of advice can we give to families as physicians, to things to look out for with respect to services and healthcare workers that are coming into our patients' homes to provide care?
Well, I think that's a great question. And, I suspect that there are many who are listening in who would have some very interesting experiences to share from what they're hearing from their own patient population. But certainly one of the challenges has been broadly that the support system for people living with disabilities is greatly stretched, and in particular the workforce of caregivers that we call in Ontario personal support workers, and they go by other names in other provinces. But as has been identified by many, this is a workforce that is highly vulnerable themselves. They have already represented a large number of those who have been infected. They're paid usually minimum wage. They're often racialized and living in crowded living conditions at home, take the infections from the workplace often to their home communities. And what's happened, of course, is that there have been restrictions on either recommendations or out-and-out restrictions on PSWs working in more than one place. And this has a ripple effect, not just on institutions, but on people who have a family member that's living at home with them. And so I certainly am aware of many families who would ordinarily have at least interim support from a PSW who might come into the home. And, I think that it's going to take some time until we actually hear all the stories of what happened during that period of time. But having somebody who has very high personal basic needs that needs to be fed and dressed and have their briefs changed and all of the things that it takes to care for somebody, including lifts and mobility challenges. Family members have sometimes that used to have some kind of respite aren't getting any respite anymore. And so I think that family docs, have an antenna to check in on those people anyways. But I think that there's certainly a hypothetical and probably a real risk of increased trauma and increased other challenges, including, potential domestic violence situations and lots of other mental health concerns for families that are dealing with someone living with a serious disability. The other area I would say is our public health systems are so stretched, and we have struggled in a huge way here at Participation House to get the kind of support that we needed from our regional public health unit. I can't imagine what it's like for families that have been trying to get good public health education for dealing with a family member at home. Not to mention even being able to have the supplies necessary to be able to do all of the basic caregiving needs that have to happen. It's literally impossible to do that at a distance. And I think that support for public health to be able to provide teaching and training and supplies to families at home is really critical. And the last thing I would just say is compensation for physicians and other caregivers to make it more realistic and more likely that caregivers, including physicians, will be able to provide that care in the home is something that, again, we've struggled with chronically, but in these times, I think there's a case to be made for increasing compensation for home care, and that would be a big relief to families who need to get someone to come in and help them.
Thank you, Jane. I mean, it really highlights our role as family physicians and being sort of a facilitator and coordinator and advocate for our patients and our patients' families, for sure. So there's many members in our viewing audience that are very interested in the whole thinking around advanced care planning. So I'd like each of you to speak about if you're sending someone from a vulnerable population to a hospital, are there any specific differences that that advanced care planning should be considered when thinking about advanced care planning? Jeff, let's start with you.
So in the context of advanced care planning, I think there's issues in that people can deteriorate very quickly, and you may not have had a chance to have the very important discussion about that. And when somebody's looking relatively well, there's a reluctance to say, what would you like us to do should you deteriorate? But I think it's important that we do have those conversations. So first of all, having the conversation. Secondly, I think it's important that we provide our clients all of the evidence that we have that would support whether they'll do well or not do well. If they were to deteriorate in a hospital, if they were to go to the intensive care unit, if they were to become on a ventilator. So if our clients are provided that essential information and those discussions do take place, I think we'll be much better off, and we won't be caught off guard if somebody quickly deteriorates and we're asking ourselves, my goodness, what should we be doing here?
Thank you, Jeff. Jane, you had also mentioned about the high risk, the population that you work with, and deterioration that can happen quickly. What are your thoughts on advanced care planning?
Yeah, it's a really great question, and something that I think we all, when we have a chance to catch our breath or maybe sooner, need to talk a little bit more about, because one of the reflections that I've had during this time, I mean, when I first came into Participation House, we had to review the code status or level of care status with everybody, and thankfully we had a good team. Our Chief of Family Medicine here, Alan Grill, helped to put together a team of docs that could help us, and we made sure everybody's family member actually had a call. Within about 24 hours, we were able to review the wishes of substitute decision makers. But one of the things that I'd like to raise, because I haven't really tried to articulate this before, but after a few days, realized that there's a struggle with the fact that, you know, we're comfortable with the levels of care, and we understand that people may not want their loved one to be admitted on a respirator, and they want them, but they still want their medical care provided, the sort of 2s and 3s in the 4-stage levels of care. Initially, there was a sentiment around here, and I've talked to long-term care docs who have had the same issue, that, well, you know, the hospital actually can't do much more for them than what we can do here. If we can provide oxygen, sometimes various forms of hydration, including hypodermic lysis. But what I came to realize is that I think that we do a disservice to those who still want to have the care done if we don't realize that especially in a crisis situation where you've got multiple residents in long-term care facilities or other group home congregate settings, where the hospital may not be able to do a lot more, but they can sure do a lot. They sure have a lot more support and resources to be able to provide that care. And, you know, I think we can keep people alive that would otherwise not be able to stay alive by that really high quality care in hospital. And I think what I'm trying to say is, and as I say, I'm still trying to sort of get my head around whether or not all of those deaths in long-term care facilities really had to happen, even if they were people whose families didn't want them to have full resuscitation. I believe that we have erred on the side of saying, well, they can stay in their long-term care facility or their group home because the hospital really can't do much more. And that's actually not true. The hospital actually is much better resourced to be able to do that comfort care in a way that might be able to extend the lives of people. And I think we need to review just what that looks like in the collaboration between hospitals and communities. It's frankly appalling to see how elders, seniors have died in such vast numbers. Our ageism and ableism is being worn on our sleeves by not valuing those lives and making sure that they get the care that they need when they're in a level 2 or 3 situation.
Yeah, it's a sobering and tragic situation. Jen, I'm going to ask you to speak to this from 2 different perspectives. One from an Indigenous cultural perspective, to think about with advanced care planning, but also you made a very important point there that many Indigenous are off reserve. So there are many, they don't have to be, not every Indigenous is, not the largest population may necessarily be remote. In fact, there are many in our cities and in our dense populations. So, are there, from those 2 perspectives, talk about advanced care planning in that Indigenous population for us?
Yeah, I think it's important to, you know, make the difference. There are remote communities that can be Indigenous or not Indigenous, and there are many Indigenous people people living in urban centers, and that varies across the country. But in many provinces, it's roughly half of Indigenous people that live in urban settings. So I think it's important to make that distinction. And I can mostly, I can only really speak to the situation that I know and that I live, which is the community where I work and live. And certainly, I think, I'm very passionate about goals of care discussion. I think they're incredibly important. It's something that I've been passionate about for a long time. And I think, a silver lining of this pandemic might be that we're talking about it a little bit more when a lot of us were kind of avoiding those discussions before. I think they can be done in a culturally safe manner anywhere around the world and with people from diverse backgrounds. We just have to know our patients in our communities as well as possible to do it. I think we've been fortunate that because we care very much about goals of care, we had been discussing it with most of our elderly patients for a long time. So we actually did not have that many patients that did not have a goal of care discussion recently, or charted, so we know what to do if there's an emergency. But this has definitely been an impetus to look into it and see who we could have missed and have those conversations. And they're certainly not easy, but I find that they are incredibly touching moments. And this is not a question of, do we do CPR or not, but it's really an opportunity as family physicians to learn more about what our patients care about, what are their values, what are their preferences, how do they want to live the life they have and the time they have left, no matter how much time that is. And something we hear often in the community where I am is that people want to stay in the community. And I think people are very aware that they could get, from a medical perspective, higher levels of care outside of the community, even for supportive care, even for palliative care. Certainly we can't do as much as a hospital or palliative care home could do in the South. But the connection with the land, the connection with the community, and to be surrounded with your family and your friends, this is something that's important for a lot of people around the world, but that's certainly something that is particularly key in many Indigenous communities where, the connection to the land is a lot stronger than in non-Indigenous communities in Canada. So it's something that is very recurrent when I speak to patients and with patients about this, that they say immediately when I start this conversation, say, I want to be in the community. I don't want to leave if there's, a strong chance that I won't come back. I want to spend my last moments on my land. And that makes so much sense. And that is so important. We have to find a way of providing them good care locally, because it would be, hugely disrespectful to tell an elder that they have to leave their community in all cases. But it's a particular issue for Indigenous communities where children have been ripped from their homes and ripped from their families to go to residential schools not that long ago. So certainly, I don't know any physician or nurse who would, force or push a patient to be transferred. And we should never even consider that, particularly in the historical context that we're in, but also in general.
Thank you, Genevieve, for those insightful comments. One of the hardest jobs as the host is to keep track of time. And unfortunately, we are running out of time. And this is, I think, a topic that we could talk much longer about. In fact, I have the final question is around what resources that are there for family docs to access with respect to being more aware of or being able to access with respect to vulnerable populations. And are there things that we haven't thought about, like how do we use our EMRs to better identify at-risk populations? And there are other at-risk populations, such as the WHO, who has coined the phrase the shadow pandemic, where with spousal abuse and child abuse. And so I think if you could each leave us today with a sort of a recommendation or some resource that you know of that you think would be helpful for your colleagues, that would be wonderful. So Jane, I'll start with you.
Well, I think that thing that I would suggest is, as this pandemic has pushed us in so many areas, one of the areas to loop back to where we started is that we need to use the pandemic to try to deal with the terrible fragmentation that we all know is one of our biggest problems in healthcare systems across the country. And so this is a chance for us to try to build those links between primary care and public health and hospital care that have been so weak over a long period of time. I have to say that Markham Civil Hospital, which I've been affiliated with for a very long time, has reached out to long-term care homes and group homes in a community in a way that they've never done in the last 20 years that I'm aware of. And it's like it suddenly put the community and vulnerable populations on their radar. They suddenly became aware that there were 100 congregate settings in York Region that, in addition to long-term care homes, and so and they literally started to go down the list and try to figure out whether people were ready and what help they would need in the way of PPE, et cetera. So I think the resources are there in front of us, and we need to take this time to push those who have more to be able to take responsibility, a greater responsibility for the have-nots. I think there's going to be a lot more work to do. Public health has been under-resourced for years. We have to all push for it to be better resourced, to be better staffed, and we also need to build those links. So I would say that's an area we need to work on.
Thanks very much, Jane. Over to you, Jeff.
I won't take very much time because I know we're out of time. I would just like to say that, the fact that we have trouble thinking of what resources to provide for people means that this has really caught us off guard. And I'd like to echo what Jenny said right at the beginning, is that now's the time to start to think about how we rebuild and how we prepare for the next challenge, whether it's a second wave or whether it's another disaster or something. And I think it's trying to build resilience back into these communities so that they can weather another challenge, and that'll be so important. And I think I would be remiss if I didn't highlight the importance of preparing and supporting our front lines, and that is the doctors, that's the nurses, but it's also the janitors, the cleaning staff, the personal support workers. Those people are doing, all of them are doing a yeoman's job, and I'd like to thank them all.
Thanks, Jeff. That's an important thing to certainly remember and keep in mind. Jen, I'm going to give you the last comment.
Yeah, I think in many respects, we as family physicians are actually bombarded with resources now. So I don't want to, burden any of us by saying you should also go listen or watch this. But I've seen a lot of people have the reflections that we've had today around the vulnerabilities that were already there that have been exposed. And I hope that going forward, we are stronger advocates about this, because we have been caught with our pants down, and there will be many more disasters. There will be many more pandemics in the years and decades to come. And there's climate change that needs to be tackled. And we cannot simply weather the storm and go back to what we were doing. We need to have more resilient health systems, and we need to work on those inequalities so that we are actually more equal when the next thing hits. Because many situations that were already not acceptable might not have been known or publicized enough. But I think now we all realize, the sorry state of many of our long-term care facilities, the limitations that we have because staffing is so limited and is so vulnerable to a few people leaving in our healthcare institutions, that we need to have healthcare workers move around all the time. And that has been a huge factor. All of those things need to be addressed, and they need to be addressed as fast as possible so that we are more resilient for the next big issue that we will have to face, no matter what that is.
Thank you. Thank you all. Planning and based on our lessons learned. It's my privilege on behalf of the College of Family Physicians to thank all of our speakers today for your time, your energy, your efforts. We all appreciate it. And personally as well, I'd like to thank all our viewers for your time, your effort, and for viewing. And I wish everyone a good day and for you all to stay well. And as we close out, just a reminder for our next week that our webinar will be on reclaiming your practice. It'll be your office practice during this pandemic. And the week after will be highlights from recent publications in 2019. Don't forget to claim, click on the link and claim for your MainPro certified credit for this webinar. And again, thank you all. Thank you to our speakers, and everyone, please stay healthy and stay well.